rise of artificial intelligence in sleep medicine.
Friends, I'm a thank Dr. Shankar for the opportunity. Shankar and I go a long way. Since school, in fact. He's my schoolmate and college mate. I'm an outlier here. I'm not an ENT surgeon. I'm not a sleep apnea specialist. I'm a pediatric surgeon. But I also have a different role. I'm also the founder of Curium Life, which is one of India's first surgical AI startups. I also teach part-time at IIT Madras, where I teach deep learning in endoscopy and surgery. So today I'm going to be talking about the work we are doing, and also a detailed note on where artificial intelligence in sleep apnea is evolving. I'm going to be doing a small case study of a startup. So the fundamental challenge why I started this startup was complications. We're talking about 300 million major surgeries every year across all specialties. 1 in 6 surgeries undergo complications, which is about 50 million complications. And the sad part is that 50% of them are completely preventable. So the journey started way back in 2016. I was a general surgery resident at Madras Medical College, and I had a sad job. I had to choose the list, which means that I had to choose a patient, which patient would be operated by which surgeon. And like in every profession, every specialty, the skill levels of surgeons are vastly different. I had surgeons equally qualified, of pretty much the same age, pretty much trained in the same institution, but with varying skill sets. I knew that if this particular assistant professor is going to operate, the risk of bipedal injury is significantly higher in a laparoscopy. If that person is going to do a thyroidectomy, you can expect nerve palsy. And there was my chief, he could just walk into the room and tell, hey, Vinayak, that's not where you should be going. Okay, that's a bypass. And what I wanted to do was bring in that experience into every operating room in the world. Because surgery just does not happen in academic institutions. It does not happen in ivory towns. It happens in small towns, not just in India, but all over the world. One of the first problems we started to solve was the measurement problem. I'm a laparoscopic surgeon. I do much of my work in pediatric abdominal and thoracic surgery through laparoscopy, just venturing into robotics as well. And one of the foremost problems we have is that we are not able to measure things inside the abdomen. So you're talking about bariatric surgery, where you're talking about a gastric bypass. The length of the bowel we bypass determines how much weight you lose. If you bypass too much, you lose too much weight. If you bypass too less, you don't lose weight. Or hernia surgery where you want to place a mesh. So this is surgery. My friend, she's a robotic surgeon in Bangalore, and she's doing the surgery. And she's using a scale to measure the after hernia section. That's actually okay, but this is a very famous bariatric surgeon. He's measuring the bowel loop, and he's saying, okay, this metal part is around 4 centimeters, so what I measured is approximately 4 centimeters. If you kind of look at it, surgeons, we tend to overestimate our own abilities. The error rate is around 33%. So what we built was a real-time anatomical measurement tool. This is a surgery by Dr. Hani Takla in New Hampshire, in the US. And we are able to measure distances in real time. Now you might think, okay, this is easy. But the real challenge is that laparoscopic camera or any endoscopic camera, whether it's an ENT or something, is a monocular camera. Unlike an iPhone, where there are 2 cameras, which means that depth estimation is essentially difficult. So what we are using is a combination of, we have used artificial intelligence to detect the instrument tips, train that in stress conditions. When I'm talking about stress conditions, smoke, blood, varying, as you might know, most of you are doing endoscopic work. When there's blood on the screen, the light dims because the blood absorbs the light. So, and we are using a hue and contrast model, a depth estimation model, where there's a light source and the amount of light that falls on the object determines the depth. So essentially what we're able to do is measure the x-axis, y-axis and the z-axis and actually estimate the depth. And we've deployed this in one hospital in Chennai, we have pre-regulatory. So the fundamental thing over here, what I believe should emerge into every specialty is, it's not just measurement of the depth or measurement of distances. It is understanding geometry. The surgery does not happen in 2D space, surgery happens in 3-dimensional space, which means that we are building, we have applied for near our grant along with IIT Madras for it. this is, we are building sovereign AI, we are building AI for India, and making this open source across India. Over the next 5 years, all surgeons will be actually able to build apps on top of this to solve problems in their own specific surgeries. So what essentially we're trying to do is across 8 different surgeries, across 5 different specialties, we are building foundation models. When I mean a foundation models which can identify depth, understand surgical intent, context, automate the process of understand automation in surgery, understand movement. Essentially, if you're doing a laparoscopy, if your instrument is about to be near the bile, it can give you a warning. Okay, that's not somewhere you should be going. You're doing a bad slopectomy. If you're near the pulmonary artery, you're able to identify. So, just a small demo, early work, not yet published, we are able to identify the gallbladder in real time. Also measure the distances, if you're able to come too near the duodenum, we would be able to warn you. Again, something really scary for surgeons, but in about 2 years' time, you will actually be able to measure surgical skill. Give out a score about how good a surgeon actually is. This is the future, and it also allows training programs to improve about how good you can get. So let's come to AI and sleep apnea detection. I don't need to talk about this, but this is a major problem. And it is also very India specific. We have about 100 million people estimated to have OSA. So the real challenge is, I think, I heard a couple of talks, but I think the real challenge, what people are trying to say is, therapeutics is a minor problem. Diagnostics is a bigger problem, because just like how my previous speaker told, we do miss out sleep apnea in women because it's underdiagnosed. Currently, the process of diagnosis of sleep apnea is a major challenge, which means that we are extremely hardware intensive, which again means that multiple settings, access to resources, access to hardware, costs, kind of deter people from accessing diagnostic modalities. So, a lot of things have made AI-based screening viable. The first thing is sensor ubiquity. So, if you understand these sensors, the hardware which goes behind detecting sleep apnea, there are basically things like accelerometer, gyroscopes, microphones, SpO2 sensors. Now, these are available in any standard. Let's talk about an accelerometer. Accelerometer basically detects motion. The gyroscope detects rotation. Microphone detects sound. If you are able to get all these things in a single device, it is your standard iPhone, right? Single processing maturity. Accelerometer, gyroscopes, and microphones pick up a huge amount of signals. Current neural networks, artificial intelligence modalities have made it easy for us to process those entire information, filter out information which is useless, and use information which is kind of useful. Regulatory apply. Post-COVID, there has been a huge boom in medtech devices. Essentially because medtech all over the world, especially starting off in the US, where more than 90% of the medtech innovations do occur, they have become regulatory friendly, which means FDA, which used to take at least 7 years to do an approval, is able to do that in 7 months. I think that has been a big game changer. I think you must thank COVID for this particular thing. There are multiple companies that are doing Apneal, Sunrise, Sleep is one. You have your watches, your Apple Galaxy Watch. I want to take one startup which is Apneal. This is a French startup, and I had the opportunity to actually witness their device, talk to the founders as well. So essentially, this is what Apneal does. It captures your data. And how does it do it? There is a phone which is strapped to your chest. They have a chest belt. You put that phone in airplane mode, switch on that app, and go to sleep. There are no restrictions on how you should be sleeping. Absolutely no restrictions. Again, there are 3 most important points. First is the microphone, which detects snoring, which detects breathing sounds, which is able to detect silence as well. And information is captured at a frequency of 8,000 hertz, which means that every second at 8,000 different points, the information is captured. Then there's an accelerometer, which basically detects the rise and fall of your chest. And again, that captures information 100 times in every second. And then there's a gyroscope, essentially, which rotates your rotating motion. You're moving around and all that sort of stuff. Again, I won't get too much into the specifics because it can get a little overwhelming, but feature extraction. Feature extraction is essentially it processes that information and puts it into a deep learning model, which is a convolutional neural network. In simple languages, the convolutional neural network is like a brain. Okay, so there are neural connections over there. So, unlike your brain, where once you get some information, neural networks are formed, right? New connections are formed. In a neural network, those connections exist. You essentially populate it with information. I don't know how many of you have played this game Brambita. There's a big board, and there are holes, and there are goalies, marbles which you place. So your neural network is like that, you know. There is this neural network, and you populate it with these marbles, which is the information which you'll be able to give. Okay, and then there's a clinical output. So I won't again bore you with too much of the specifics, but essentially it creates feature maps. And gradient recurrent units are units which are able to process information, you know, in a continuous manner. Say for example, the information it processes changes with every patient, which means that your breathing patterns are analyzed and stored, and that pattern is taken over to the next second as well. So it creates a comparative map. It's not like a snapshot. It is a continuous process of assessment. And what they found was that the deep learning models had extremely high levels of accuracy. And this was very valid, especially when the AHI was greater than 15. So again, so they're at a patient level and at an event level segmentation, the positive predictive value and sensitivity was very high. And this is how your report looks like. It gives you a sleep, it gives you a detailed analysis of your sleep patterns, it tells you whether you should be consulting a specialist or not. Again, what are the challenges in this? There can be movement misclassification. So there are people who have periodic leg movements. Extreme amounts of leg movements can confuse it, can be confused with respiratory recovery movement. Beta blocker usage is a major confounder, which the founders of the app are trying to solve currently. And then there is sensor displacement. The phone is strapped to your chest at a particular position in the center, but if it moves due to some reason, you are a rough sleeper, then again the sensor can be misplaced, and there's a referral population bias. The studies were performed on people with sleep apnea, which means that the initial study was done on 44 people. The training model was done on 44 people. Only 7 of these people had an AHI of less than 15 per hour, which means that you start off with a baseline population which is currently sleep apnea. So the real challenge for you guys over here, you are the future of sleep apnea in India, or perhaps even the world, is that what can you do to replicate this or create something even better in the Indian population? There are multiple advantages you have. One, even inside the abdomen, we have found that, we are building models in hernia surgery. The first time, I'll give you a small example. We built a model and we placed our system. We trained a model on data from Chennai, Madras Medical College, Ramchandra, Grant Medical College, Bombay, DMC Ludhiana. We thought we had a great spectrum of patients in different areas. Then we took a hernia model and placed it at Mass General Hospital, Harvard. Within 10 days, the radiologist called me and said, your model is useless. It's not able to detect a hernia. This was a radiology model, which was one of my earliest projects. He said it's useless because the average BMI of a person in the US with a hernia was more than 42. And in my entire training data set of about 425 patients, I had only 4 patients who had a BMI of greater than 40. Whereas 70% of the patients there had a BMI of greater than 40. Which means that there is a huge amount of population variation. Which means that deep learning models which are built on Western data are essentially going to be useless or can overdiagnose or underdiagnose. And what's more, you will actually be paying for that through your nose to do this. The best way we need to do, especially for the past years, we had a significant amount of government grants funding. In fact, we have been funded. We have been supported by the government of India, We were a part of the Bharat Innovates program, where we were selected by the External Affairs Ministry and the Education Ministry to showcase at the G7 summit as well. This was last month, and I think you guys have a great opportunity to create such tools for the Indian population as well. So the market size is huge. If you're able to build this on Indian data with one of the largest populations in the world, I think we do have a great solution in hand. So the bottleneck in OSA is diagnostic access, not therapy. 90% of the 900 million affected people are underdiagnosed. I think that's the most important problem to solve. And 104 million patient burden, this is the ideal population to build hardware-free AI science models. Thank you so much. I strongly believe Lord Kelvin's quote where he said, if you can't measure it, you can't improve it. Thank all the institutions that shaped me. My alma mater is Thuyilcon, Madras Medical College, and I did my CHS in Medical College in Jaipur. IIT Madras and Mathas Hospitals where I currently work. Thank you so much.
Knowledge of these AI platforms, every doctor has previously the doctors they don't know coding or anything, but with the AI platforms available, everyone has become an engineer also. So we hope we'll have more products from our fraternity also with this help of this AI platforms. And I am very much astonished by that measurement tool, that computer vision. We'll talk about it.
Absolutely, sir. Yeah.
Dr. Vinayak, just like you said, doctors it's not truly impressed and it's an eye opener. What you said in the last time, we need to have normative data from our population. Is that what for the input for the studies in normal people? To have the AI to analyze your measurements?
Yes, ma'am. Yes. I think the big challenge in the Western population is access to data. So this particular study was done in France, where the data privacy laws are extremely restrictive. And I had these particular founders reach out to me saying that why can't we get normal patient data from India? And the first thought which came to my mind was why are we not building this in India when it's technically super simple to build this? All you need is a signal processing guide and data from your mobile phone. You are able to get the accelerometer data, gyroscope is available, it's a microphone is available. It's basically a signal processing problem where there are 4,000 engineers or 5,000 engineers in India who are sitting without a job and very well trained in signal processing. So I think we can do this in India. The first thing is obviously we need centers to cooperate. We need people. Obviously, when you're building a startup, there is a monetary investment. Unfortunately, one thing which I have found, it's been 4 or 5 years since I started building this process. India per se, or even all of Asia per se, we have strong inhibitions to investing in something new. Which is why deep tech investments in the country are extremely low. We have startups like Swiggy, Zomato, which are coming up on a massive scale, but even venture capitalists in India are extremely averse to investing in deep tech, where the results take about 8 to 10 years to come on. I mean, a simple example would be the fact that OpenAI first started its development work about 12 years ago. It's taken them about 10 years to reach a commercial model. So deep tech is expensive, deep tech is painful, but for any country to grow, I think deep tech is super essential. And there's just like we saw, Anthropic came out with their mythos and fable model, and Trump came one day and said that you can't give it outside India. I think that's a strong wake-up call for us because one day we are going to be left out of this intelligence race if we are not able to build sovereign AI. And I think that's the point which I want to make. If you want this country to grow, you need to build in India and sell it to the world, for sure.
Absolutely, you're right. I think persistence, all the best, and very, very impressed. I'm sure they will take us to help you out.
Thank you.
Yeah.
Thank you.